Assalamu alaikum wa rahmatullahi wa barakatuh. For this session, we will start with the unit fecal elimination. In fecal elimination, the first objective that we will cover is to review the anatomy and physiology of the gastrointestinal tract, and then we will go to the factors that affect fecal elimination. Then we will go to the problems and also the cure for those problems or alteration in fecal elimination. So we will start with the digestive system. So the digestive system, it is started from the mouth, and which is considered from also the first thing of digestion. It will start in the mouth itself. So by chewing the food and also mixing it with the saliva. Then it will go to the esophagus. From the esophagus, then the stomach. At the stomach also, most of the chemical digestion, it will happen there in the stomach. And then after digestion, after it is digested in the stomach, it will go to the small intestine. Also, some chemical digestion, it will happen there in the small intestine through the pancreatic juice, and also through the liver or gallbladder excretion. Then after that, we will start to deal with the changing that food, and the intestine absorption will be there. Then it will be formulated to stool in the lower part of the small intestine and at the large intestine. The large intestine, when it is composed from three: the ascending colon, transfer colon, descending colon, and then it will go to the sigmoid and rectum and anus. So the formation of in the large intestine, mostly water will be absorbed, and by that the food, it will, or that end product, it will be formed as a stool. And also there are many processes which will be there, but you can refer back to anatomy and physiology in order to understand that, as you took in anatomy and physiology. The factors that influence defecation, we will start from the developmental factor. Developmental factor during or after birth, there is the child or the new infant, he will pass meconium within 24 hours. That meconium, it is usually black in color, and also it is sticky, so containing some mucus. It will be for the first few days. Also, the intestine is still, or the digestive the digestive system, it is not developed well. Because of that, also the infant, he mostly will pass a stool mostly after feeding during the first month of life. And also he cannot have a control over the digestive system or over the defecation. So usually after each feed, he might pass a stool. By the age of 18 months, the child, he will start, or we can start toilet training with the child, and we can help him to control his defecation. Then after that, it depends upon there are many factors that will affect that. By the aging, by an old age, our movement it will be decreased, our activity it will be decreased. By that also the peristalsis movement it will be sluggish. In this case, mostly old age, at old age they will complain from constipation. About the diet, it will affect the defecation itself according to the diet that we are taking. So if we are taking more fluid, in this case, our stool it might be loose and it is easy to be passed. If we are not taking enough fluid, in this case, we might suffer from constipation. Also, the amount of fiber that we are taking in our diet, when we are taking too much fiber, in this case, loose stool, it will be there. If we are taking less fiber, then it will tend to have a hard stool. The activities of daily living, the usual activity that we are doing, the exercise that we are doing. So according to the mobility, when we are increasing our activity, when we are increasing our mobility, by this we are enhancing the peristalsis movement. And by that, it will affect or also it will be help in the defecation process. Psychological processes also. Our psychology, our emotion, it will be affecting the defecation. So if we are anxious, we might have high peristalsis movement, and we might, due to stress that we are having, sometimes we might have diarrhea due to the anxiety that we are having. If we are having depressed mood, in this case, also our activity it will be low, the peristalsis movement it will be low, and in this case we might get constipation. Also, defecation habits. So defecation habits, most of the people, they are having a habit of defecation at early morning when they are waking up or after breakfast. So when we are taking food, this will enhance the bulk movement of the stool toward the rectum, and this will help in the process of defecation. When we feel that when the formed stool is going toward the rectum, then we will feel the urge to go to the bathroom. The problem, if we are ignoring the defecation, the urge for defecation, in this case, this urge, it will be inhibited. If we are ignoring that too many times, in this case, we will develop constipation. Yes, we might be in need for suppression of the urge for defecation in case if we are too much busy, but it should not be for a long period of time. If we are at work sometime, so if it is as a habit, we are inhibiting and ignoring the urge for defecation, in this case, constipation and hard stool will be there, and we will have difficulty in passing stool. Medication also, it will affect the defecation and the process of passing stool. Like if we are taking a strong analgesic or anticholinergic, in this case, it might suppress the motility of the intestine, and it might lead to constipation. Diagnostic procedure. Diagnostic procedures, some of the diagnostic procedure also might interfere with the defecation, like in case if we are taking barium meal or barium enema, it might also lead to constipation after that. Also, for endoscopy, especially lower endoscopy, in this case, the client is in need to take fluid diet for the last day or sometimes for the 2 days. He has to take also laxative in order to clear the stool which is there in the intestine, to have to give opportunity for proper diagnosis. Also for medication, those who are taking laxative for a long period of time, in this case also it will affect their ability to defecate. Anesthesia and surgery, especially surgery if it is in the gastrointestinal tract, it will affect also the defecation and the ability to defecate. If it is in the lower part of the gastrointestinal tract, sometimes also if colostomy is there, so it will affect the mode of defecation. So instead of defecating through the anus, in this case, he will be defecating through the ostomy. The anesthesia itself also, it will decrease the motility of the gastrointestinal tract. Also, before surgery, we have to ask the client to go to the bathroom and pass a stool if he has a stool. Otherwise, because the sphincter also due to anesthesia, it will be relaxed and he might pass a stool. Pathological condition like cancer, like infection, recurrent infection, that might lead to infection of the gastrointestinal tract, which will lead to diarrhea. Also, pain, especially those who are having any condition in the lower gastrointestinal tract or in the rectum or at the anus, especially for those who are having hemorrhoid. They will have pain or anal fissure. They will have pain while they are passing stool. Because of that, some of them, they are ignoring the urge for defecation. And when they are ignoring the urge for defecation, the water from the stool, it will be reabsorbed, and by that, the stool, it will become more harder, and it will be difficult to pass the stool, and the pain also, it will be more when he wants to defecate. So, in alteration of bowel elimination, we have one of the alterations which is constipation. Constipation, it means either hard stool, so which not easy to pass it, and also when the client is having less than 2 or no less than 3 bowel motion per week. This is considered as constipation. So if he is not going for defecation, if he is going less than 3 times per week for defecation, in this case, it is considered as constipation. Fecal impaction. Fecal impaction, it means that the stool is hard and it will be impacted. The client will feel that the distension is there in his rectum and he wants to go to the bathroom, but he is unable to pass stool due to the hard stool. It might be fecal impaction, it might be due to ignorance of both of them. It might be due to ignorance of the urge of feeling that, when the urge is coming for defecation, that when the client is ignoring it, in this case, it will increase the possibility for fecal impaction and constipation due to reabsorption of water from the intestine. Diarrhea, Also, don't forget that in constipation, it depends upon the diet that we are taking. If we are taking less fluid, if we are not taking fibers, also if we are taking some food that it is like potato and those starch containing, high starch containing food, in this case constipation it might be there. But if we are taking fruit, if we are taking more fluid, if we are taking high fiber, if we are taking cereals, all of those, it will help in the ability to pass stool normally. Diarrhea. Diarrhea, it is passing loose stool. It might be due to infection, gastrointestinal infection, so it will be or it might be due to the diet that we are taking. If we are taking more fluid, if we are taking food that have too much fiber. Incontinence. Incontinence, it is inability to control the passing stool, to control the sphincter. Incontinence also, it might be sometimes temporary, just due to diarrhea. So because the stool is liquid mostly, in this case, the client is unable sometimes to control that the passing of stool properly. But in most of the cases, incontinence, it is due to spinal injury. It might be due to, so it is due to the innervation. Fluent or gases, presence of gases and distension. It's mostly due to consumption of starch, it's consumption of carbohydrate, and by the bacteria which is there in the intestine, it will be fermented and it will produce gases. So it depends upon the diet and it depends upon the type of bacteria that we had in our GI tract. So constipation, it is due to insufficient fiber intake. If we are not taking high fiber, if we are not taking fruits and vegetables. Insufficient fluid intake also, if we are taking less than 1050 ml of water per day. Insufficient activity and mobility, because the mobility and the activity, it will enhance the peristalsis movement and it will enhance the process of the pathway of food in our intestine. Irregular defecation habit, if we are ignoring the urge to go to the bathroom, the urge for defecation. Also, change in daily routine, like if we are working for, like as a health worker, sometimes we are working at night or more night shift, or we are working at day shift. And in this case, those changes, it will interfere with the daily routine, it will interfere with the defecation, and it might lead to constipation. Also, if we are going for certain, for visiting others sometime, we might be embarrassed to ask for going to the bathroom, and this will interfere with ability or passing stool, and it will lead to ignoring the urge, it will lead to constipation. Lack of privacy. You know, for defecation, we need to have privacy. We have to be, we need to have a bathroom. We we need also to be alone in this case. If we are sick and if we are unable to go to the bathroom by ourselves, if we need help to go to the bathroom, also this will, by that, the client will feel embarrassed, and also it will lead to emotional disturbance, so that he will ignore the urge for passing stool. He also feeling embarrassed to ask for a bed ban from the nurse or from the caregiver. By that also it will lead to constipation. And mostly in those cases we have to take care of those clients, because sometimes also they will not take more fluid, they will reduce their fluid intake and food intake in order not to have the feeling of embarrassment when they are asking for a bed ban or urinal. A chronic use of laxative and medication, it will lead to sluggish bowel movement. So the bowel, it will not start, the peristalsis will be suppressed unless we are taking laxative or enema. Irritable bowel syndrome also, it will lead to constipation. Pelvic floor dysfunction or muscle damage of the pelvic floor. So by that, the ability of contraction of those muscles in order to, and the relaxation of those muscles in order to pass a stool, it will be affected. Poor mobility and it will lead to slow transit or movement of the food in our GI tract. Also, neurological condition and habitual denial and ignorance of defecation and urge for defecation. Fecal impaction, which means collection of hard feces in the folds of the rectum, and the client is unable to pass them. It's caused by poor defecation habits and constipation, recurrent constipation, medication that we are having, radiological examination sometime by barium. So barium is the thick material that it is difficult to pass it. Also, patient has desire to defecate, but he is having also rectal pain, anorexia. So those are the signs and symptoms that he will have. So he has a desire to defecate. He is having rectal pain due to rectal distension and presence of stool there. Anorexia, severe loss of appetite, distended abdomen, nausea. So he will feel nauseated, he will feel that he wants to vomit, and vomiting might be there. Can be treated by enema or substitutes, stool softener, and if it is not going out, it might need a manual removal by fingers. About diarrhea, it is passage of liquid feces and increase in defecation times. So either the feces is in liquid form or not formed, or more frequently he is going to the bathroom for passing stool. So it is number of times of passing stool. It can be caused by psychological stress. If we are under stress, this might increase the motility of the intestine. By that, by passing time, it will be less, and so we will have there. It will not be digested well, and also the water will not be absorbed. medication that we are having. Some of the medication that it might also increase the possibility of diarrhea, and like antibiotics, medication that contain iron, allergy to medication, disease also in the colon, unclear environment, and food, contaminated food or water. By that, it will lead to infection and it will lead to death. Presence of cramps, spasm of the muscles, and it will lead to abdominal cramp. Increase in peristalsis movement will be there. Fatigue, feeling fatigue, weakness, and emaciated. So the client will become weak because of the passing of stool, and he will lose fluid, so water and electrolyte imbalance will be there. That will lead to more weakness and emaciation. Incontinence, it is loss of voluntary ability to control fecal through anal sphincter. So the client cannot control the passage of stool. Partial incontinence, it might be partially, which is inability to control fluids or sometimes minor soiling in case of diarrhea. Major incontinence, which is inability to control feces. It's caused by impaired nerve supply to the anal sphincter, neuromuscular disease, spinal cord injury or trauma, injury to the sphincter, and spinal injury. Treated by repair of sphincter or colostomy. Colostomy, which is opening through the abdominal wall, to the colon in order to get the stool out from that opening. So either the colostomy, it might be temporary or it might be permanent. Permanent, it might colostomy in cases of C. rectum. So in this case, they will do surgical removal of the rectum, and they will do diversion. So the colon, they will connect it to outside of the abdominal wall, and the client will be defecating through that artificial opening to, or colostomy, to a bag. Fluids or gases. So it is caused by bacteria on the chyme. Chyme, it is the digestive food which is going to the intestine. Or the gases, it might be swallowing of air or gas. Also, it will be diffused between the bloodstream and the intestine. So some of it will be diffused or absorbed, and some of it will be diffused from the bloodstream to the intestine. Caused by food. So the type of food that we are taking, if we are taking high sugar, the bacteria that we are having, it might be if we are taking antibiotic, and after a course of antibiotics we might have vitamins. Abdominal surgery, after abdominal surgery, intestinal obstruction also it might lead, or narrowing of the intestine in an area. Narcotics also, because it will lead to it will interfere with the peristalsis movement, it will decrease the bowel motion. when the bowel motion is decreased, it means that it lead to formation of gases. It can be relieved normally or by insertion of rectal tube. So it can go as a fletus outside from the rectum, or sometimes we might need a help of inserting a rectal tube in order to get the fluids outside. And there are also some medications that will decrease the possibility of forming flatus. We have to change also our diet and avoid the gas-forming food. By that, it will reduce the possibility of having flatus. Assessment of health history. We have to assess the usual pattern of defecation. So we have to ask the client how many times he is going to the bathroom for defecation, when he is going, is it daily or weekly. So normally it should not be less than 3 times per a week. So in some text you find it that it is 1 to 3 times defecation, normal defecation 1 to 3 times per day or a week. So and also change in the bowels or using of, is the client is using any aids or anything to help him in elimination. Change in the bowel itself. Did he has infection or gastritis? Did he have any change that he is having? Any discomfort, any distension that he is having? We have to assess it. And also, is he using any aids for elimination as laxative, either tablet or substitutes or enema? The current problem that he is having. And when we are asking about the current problem, we have to ask when it is started, so can he describe it? What is the problem that he is having? In physical assessment, also, we have to start with inspection. We have to inspect the contour of the abdomen. And also note if sometimes a visible peristalsis movement. So when we when we check the abdomen, we have to see, and we have to check the contour by meters to see the diameter of the abdominal contour, and also see if there is a visible, sometimes we will see the movement of the intestine, and it might be visible from outside in some cases. Auscultation. We have to listen to the bowel sound and also in all the four quadrant of the abdomen. So we have to listen for the intestine and for the bowel sound and in the abdomen. Percussion to see resonant, tympanic, and dullness. So resonant, it means that there is presence of air. Dullness, it means that it might be due to constipation, or if dullness, when we are doing percussion over an organ like over the liver, we will feel the dullness. If it is in the upper quadrant, when we are going down, we might feel that there is some tympanic due to presence of gases there, or resonant sound. Palpation. In palpation, you can feel the tenderness if the client is having pain when on touch, and also you can feel if there is any mass or distension. So we can feel it by the palpation. About the characteristic of stool, we have to observe the amount of stool. We have to ask the client about the amount of stool that he is passing. Also, the form of stool, is it formed or is it loose stool? The color of stool also, usually the color of stool is brown in an adult. In infant it is straw in color or yellow in color due to the improper digestion. If abnormality, you can find that it might be dark, black. It might, in this case, it might be due to presence of blood, but we have not to mix between. We have to ask the client about the food that he is taking during the last few days, because the food itself also, it will interfere with the color of the stool. So if he is taking green vegetables like spinach, it will interfere with the color. It will change the color of the stool to dark or brown. If he is eating lamb liver, or in this case also, it will change the color. The odor of stool, usually the odor, it is aromatic odors. It will be offensive if there is bacterial changes or if there is infection. So the odor, it will be offensive odor. Consistency of the stool, so it has to be formed, not loose, not hard. You can see also the table in page 1335 in your book for more detail about the characteristic of stool. Intervention to promote elimination. So how we can help the client to or the person to promote normal elimination. The first thing, we have to provide privacy. Provision of privacy, it will be helpful to pass stool, because it is, yes, it is not a reflex. We will feel the need for passing stool, but also we will ignore it unless we have privacy to pass the privacy, and if we are able to go to the convenient place and convenient setting in order to pass stool. Timing. So we can help the client in order to have a scheduled time for passing stool. Also, diet itself. So we can change, we can interfere with the diet in order to take a nutrient diet which has a normal amount of refuges and fibers, and also to take a sufficient amount of fluid in order to prevent constipation or diarrhea. Doing exercise and activities. When we are doing routine exercises, daily exercises, in this case, it will be helpful for our intestine to work well and to pass stool well. Also, positioning. We have to help, even if the client is unable to go to the bathroom in a bedpan, we have to put him in a sitting position in order to help him to pass stool. So the position also, it will help in the passing of stool. Thank you. Is there any question?